Okay, so today we have three amazing presenters. We have David Worsnick and Julie Gutowski from Spectrum Human Services, and we have Elizabeth Kleek from the Institute for Community Living. As a reminder, these webinars are recorded and they will be put up on our website. We will have about 15 minutes at the end of today for questions and answers, a little longer than normal because we recognize that this is an important webinar, and to attend to your needs, we wanted to give you a little extra time for questions and any kind of concerns that you have around outcome measures. So with that, I'm going to turn it over to Elizabeth. Thank you so much for the three of you for presenting today.
Hey, thank you, Kara. My name is Elizabeth Kleek. I'm the Vice President for Program Design, Evaluation, and Systems Implementation at ICO. And that's essentially a long way of saying that I oversee the department responsible for ensuring that we're bringing in best practices and using outcomes information to inform our work. And so I'm just going to take you through the agenda. Today we're going to cover a lot of material in a short amount of time. So this is really an overview, and we encourage you to ask questions and also to follow up with Seatac if you're interested in more information. We're going to overview what outcome measures are and how they can be utilized in practice at all levels. So within the clinical framework, in supervision, and really to provide an organizational perspective. We have a couple of slides at the end with resources. And again, we hope to leave ample time for questions. And so with that, I will turn it over to David Worsnick, who's going to get us started.
Thank you, Elizabeth. My name is David Worsnick. I'm Chief Financial Officer at Spectrum Human Services. Some of you may recognize my voice if you've been involved in some of the earlier Seatac webinars. I've done some work with the children's clinics around financial performance and benchmarking. I asked to be included in this webinar. Many times we think about outcome measures and outcome tools as supporting the clinical environment, and they do to a great degree. But there is also aspects, as Elizabeth said, that supports the clinic operation and supports some of the efficiencies. I think you'll hear that as we go through today, and I'll be talking a little bit about that a little bit later in this webinar. So we're looking at guiding principles, and they're guiding principles and concepts. And the first thing we're going to talk a little bit about is the outcome measures as a tool used to assess change in clients over time in a way that informs collaborative decision-making about treatment. I think the primary word in this first principle is tool. Outcome measures are tools that can be used in a number of different ways. They can inform treatment, they can support collaboration, they can be a focus for a conversation, and they're a tool to collect information and provide data. Outcome measures are one more tool in the toolkit of our physicians, our clinicians, and our clinics as a whole. The second principle we want to talk about is outcome measures provide a means to objectively measure success or effectiveness of treatment. I think the operant word in this principle is, for me, is objectively. One of the things that, as we think about our outcome measures, is that well-designed and well-tested outcome measures have a couple qualities to them. First of all, they're valid. That is, they measure what they say they measure. They're reliable. That means is that the measurement is applicable and accurate across a number of different situations with different clients and different clinicians. Well-designed outcome measures are not subject and affected by bias. And so in the outcome measures being objective are based in science and have a quantitative piece to it. So it's extremely important to think about the measures as being an objective measure. The third principle we talk about is outcome measures offer one piece of the whole in understanding whether or not the right treatment is being provided at the right time. I think for me, this principle talks a bit more about that the outcome measures are informative. That is, they provide another piece of information that we can use as it relates to a clinician, we could use as it relates to a specific client at one point in time or a client over time. So it is an unstructured piece of data that is information that is situational but is very powerful. And the last principle I want to talk about, which is outcome measures provide the data necessary to demonstrate to interested parties that the services provided by your clinic are effective. For me, the operant word in this principle is data. Data is a little bit different than information that we talked about above. Data is structured. It is quantitative, so data can be aggregated. It can be analyzed, whereby information may be specific to a single circumstance. Data can be used to provide information across a larger universe. And this, in terms of a larger clinic perspective, is a critical aspect of what we need to be thinking about as clinics. I don't need to tell anybody that the world is changing out there. And I think it's imperative that we as clinics are able to demonstrate what we know we're doing and not describe what we think we are doing. So the information and the data that comes out of the outcome measures allows us that ability. We can demonstrate what we know we're doing using reliable and valid data and don't have to rely upon anecdotal data about what we think we are doing. And that's a very powerful and going to be a very necessary situation as we move forward. So a quick summary, outcome measures are tools. They're objective tools. They're informative, and they provide us data. I'm going to turn this over to Julie Gutowski now. Thank you.
Hi, I'm Julie Gutowski. I'm Managing Director of Clinical Operations at Spectrum. I work very closely with David, and I enjoy working closely with David because he looks at the big picture, and he helps me to figure out how to make the big picture fit into how we do clinical practice at Spectrum, which is very important. What I wanted to talk about a little bit is what are outcome measures. They can really be considered a clinical support tool. There's all kinds of outcome measures out there that we've seen and run into, whether it was in grad school or in our current practice. They can be a survey or questionnaire, clinical tools, to assess somebody's baseline of symptoms when they're coming in during the assessment. If we have the baseline of symptoms, what we could do is periodically check to see whether the symptoms are increasing, decreasing, or whether they're remaining the same. It can provide a systematic way of ongoing assessment of symptoms. We can also look at the person's perspective as to how they feel treatment is benefiting them. Outcome measures can either be self-administered, administered by a clinician. Right now I'm thinking about a recent survey and clinical tool that I'm sure everybody has heard about, and it seems to be the newest tool, the ACE, Adverse Childhood Experiences. And basically what you can do is you do the questionnaire, and it allows you to assess whether the client has experienced certain items in their life, whether their parents were divorced and that type of thing. And then based on the number of scoring, the number scored, it puts the person at greater or decreased likelihood of experiencing behavioral health, whether that's mental health, substance use, physical health conditions. And so outcome measures, really they allow us to look at and focus and take a snapshot and compare snapshots, kind of like on the infomercials for losing weight. There's the before and after, and that's really what outcome measures can do for us during the clinical experience. So why why would it be important to use outcome measures? I think they can add a lot of clinical value, and I'm going to speak to the clinical role, and outcome measures obviously have an administrative role as well and a benefit. At Spectrum, we use the ORS Outcome Rating Scale and the Session Rating Scale, and these two measures are used. The first is the Outcome Rating Scale. When the client comes in for the first visit, it's a Likert scale. There's 4 different domains, including individually, interpersonally, socially, and overall, and they rate basically on a scale of 0 to 10 how they're doing in those areas, and it gives us their baseline of when they came into treatment. At each session, we ask the client to use the ORS again when they first come in, and what we can do is compare today's session, if they've been here for 6 months and they've had 12 sessions, compare their ORS score to what it was when they came in for the first visit. And it helps guide treatment decisions. It also helps us to allow the client to sometimes gain some insight into their progress in treatment. We also use an SRS, or the Session Rating Scale, and at the end of the slides, this information will be listed under the resources. And the Session Rating Scale really allows you to ask the client, how do they feel about the relationship with the therapist? The goals and topics that were talked about in session, is it what the client wanted to talk about? The approach or method that you used in the clinical intervention, and overall, how did they feel the session was going? Again, a Likert scale, 0 to 10, 0 being they didn't enjoy the session at all, and 10 being it was the best clinical session they ever had. And so how we use these in treatment is basically it allows us to serve as a roadmap so the client knows where they are in terms of it complements the individual action plan or the treatment plan. A good example how I use these outcome measures was I was working with a client. She was 16 years old. When she had first come to see me, she had experienced suicidal ideation almost all day, every day. And so obviously when she first came into treatment, I was seeing her very frequently, a couple times during the week. And then as things seemed to be getting better, her depression seemed to be lessening. Obviously the visits spaced out. I let the ORS guide me with that. And then the SRS, the Session Rating Scale, allowed me to have a lot of conversations with her to make sure that the approach that I was using was a good fit for her. It really looks to increase engagement in that way. And so I had been seeing this client for approximately 8 months. The depression clinically appeared to be lessening. Her suicidal ideation had gone to, maybe a fleeting thought every couple days. But when I talked to her about her symptoms and her perspective about how she felt she was doing in treatment, she reported she really didn't see much of a difference from when she had first walked in the door to 9 months later. So what I was able to do with these outcome measures, because they were used at every session, was to use them as a way to show her progress in treatment. To talk about when you first came in, your score at your ORS, how you rated your life, was a 12. And, currently today, 9 months later, you're at a 20. What do you think would need to be different in order to continue to increase your skills? And really use them as a nice tool. With that being said, I'll turn it over to Elizabeth.
Okay. Thank you, Julie. So just as the tool is a communication mechanism for the clinician and the client, it's similarly a tool for the supervisor and the clinician, and for the supervisor. So it's another piece of information where the supervisor can be speaking with a clinician. For example, if the clinician is stuck with a particular client, thinking about how to move forward, or in discussing discharge across a range of clients. It's really it's helpful, and I want to emphasize that the supervisor really needs the same level or even a higher level of training and support on the tools as the clinician does. because the supervisor is the person who's going to support the clinical use of the tool over time. And so, in terms of in terms of just thinking about the tools themselves, measures have overarching scores, scales and subscales. So thinking about tracking change at a global level, this is really where the supervisor can look across clients that are being served in the clinic and really understand the bigger picture. So I don't want to lose what Julie was just talking about in terms of the more granular level, where the tools really help to facilitate the communication with a particular client. And individually, it can help with setting goals and objectives and with clarifying treatment priorities. But it's also a really good tool on a larger scale. So understanding the symptom scales and overarching change over time, the supervisor can be looking at understanding trends across diagnostic categories, understanding who is coming into the clinic and who is being served by the clinic. The supervisor might identify that scores seem to move in a predictable way for one diagnosis, but not as much for another. And so that's really food for thought and might provide information about where clinicians and or clients might be struggling to really impact symptoms, and where training on evidence-based approaches could be helpful. Or also in understanding if the tool isn't right across diagnoses, and maybe more symptom specificity is needed in terms of what's being measured. So it can really help with management at a management level, both in understanding trends across the clinic and also in honing in and documenting client outcomes, and that the treatment that the clinic is offering is effectively targeting client symptoms. And so David, I think, is going to speak about it on an even broader level within the clinic.
Thanks, Elizabeth. Well, I think one of the challenges that we face as we think about outcome measures, I mean, there's a great deal of interest in this webinar. So there's a lot of talk, there's a lot of interest. People understand the necessity, they understand the value that it brings to the clinic, but it's difficult in many cases to implement an outcome measure into the clinical work. It means cost related to training individuals. There's a cost related possibly in materials. As we're training people, there may be some lost productivity, and it's one more thing that we're asking our overburdened clinicians, one more thing to perform, one more form to fill out. And sometimes I think there's some pushback, and so there's some reluctance, given all the other things that are going on, to be able to bring this forward and integrate it into practice. One of the things, though, I think we need to think about is the value that is returned. And I think as I was thinking about this, there is a value that it relates on a broader level, and the value is returned to the clinic. And the first piece here I talk about is outcome measures support efficiencies by quickly providing information about the client's level of need and level of care. So I think that when we think about if we have an ability to match need with our level of care, I think that we're going to find a couple things that may happen. We may find with a better alignment that we may see some of our no-show and cancellation rates go down. This is as our clients become better engaged, as they our services are more aligned to their needs. They're able to communicate to us. There's certainly a higher level of engagement. I think that once you are meeting the needs of the client in a more efficient way, what we might see is a shorter length of stay. As clinics are struggling with open access and be able to meet the needs of the community and the clients, If we have a better alignment as our clients move through treatment more quickly and more efficiently, then that opens up access and capacity to serve more people. And I think, as we've talked about with our other work, when you begin reducing the no-show and cancellation rates, then you certainly have a more efficient use of the clinical hours that are available to provide services. So some of you may have worked in some of our earlier work, and I have a model where I can demonstrate quantitatively that you can spend money to increase efficiencies, and the value returned from those efficiencies exceed the cost. I'd like people to think about that in the broader sense as it relates to the outcome measures and how that applies to clinic. The other piece, and Elizabeth talked a little bit about this, is outcome measures support efficiencies around allowing supervision to be more directed. Supervision can then be more efficient. We have an ability using outcome measures to more specifically target our training dollars. It is an opportunity for us, particularly within some of our newer clinicians, to gauge where they are, gauge their engagement abilities, and really focus and hone in on those non-billable hours that are critical to support the clinical operations. But if we can use them more efficiently and more effectively, that's certainly going to return value not only to the clinic and our clients and the clinician, but to the general population. The last thing I have on here is outcome measures are critical components of a balanced scorecard demonstrating efficiencies and effectiveness. A balanced scorecard. Let me give you, I'm going to bore you with an example of what I'm talking about in terms of a balanced scorecard. One of the things that we do know as a clinic operation is that there are a number of purchasers of our service out there. Our individual clients may have co-pays or deductibles. They may purchase services out of pocket. We have the Medicaid system as a purchaser. We have Medicaid managed care that is becoming a larger and larger purchaser of services. We have a government purchasing services. We have grants purchasing services. And one of the things that I think about is how do people make decisions about what they're going to purchase. So let's use an example. I need to buy a car. I've taken a job in a new city. I need to buy a car to get back and forth, and so what am I going to do? Well, the first thing I'm going to do is I'm going to know what type of car I need. And I'm going to go out to consumer reports, and I'm going to look at consumer reports, and I'm going to start taking a look at the quality of the choices that I have for purchase, because there are many choices available to me. After I get an idea of what the quality is, then I'm going to start looking at price. I'm going to jump out to the websites. I'm going to go to dealerships. I'm going to start comparing. Once I understand the quality of service, the quality of what I'm purchasing, I'm going to start taking a look at price. And after I hone in on the price, what I'm going to do is I'm going to start looking at reviews. What do the people who purchased the service or used or purchased the product, what do they say about it? Does it work? Is it consistent? Do they like it? And so what we have is in the purchasing environment, people are taking a look at quality, they're taking a look at price, and they're taking a look at reviews, what people have to say about this. So when we circle back to our clinic, when we circle back to talking about what we need to be able to demonstrate, what we need to be able to provide, we need to be able to provide that balanced scorecard. We can take a look at the financials. We can tell people what our services cost. The outcome measures allows us to be able to articulate quality. Quality, what we are able to accomplish, how our clinical interventions are working, how people's lives are being improved, and we are able to demonstrate that in a balanced fashion with our outcome measures. The third piece of this is the reviews. Then we take our reviews, we take our client satisfaction surveys, we take our client testimonials. So you take your quality, you take your price, and you take your reviews, you bundle that with your mission, and you have a very powerful message to make to those purchasers of service. So I guess the takeaway for me on this is, yes, this is in some sense a costly endeavor, but I think that you'll find that the efficiencies that is returned to the clinic, the value that is returned to the clinician and to the client, and the information that is available to provide about what we're doing, those values far exceed the cost of putting this in place. That's it for that section.
Okay. Thank you, David.
So
I'm going to cover a little bit about how do we use outcome measures effectively. And I think that the very first piece of that is needing to choose the correct tool. So you really want to think about what you want to measure. And again, tools are one piece of information in understanding the whole picture. So in school, we all learned about conducting assessment interviews to understand the needs of the client, the diagnosis, et cetera. And specific tools have been crafted to support that process. So to screen for diagnoses, for example, the CESD, or to track change over time across a range of symptoms, you know, the OQ45, the BASIS 24. But the tools really need to be selected in accordance with what you're hoping to measure and what you're hoping to understand, and then used in context with a full range of information. So you may want to use the tools on a quarterly basis to get a point-in-time sense of how the client is doing. And what's really important is to make sure that the client is asked about the time frame specified in the tool. So you're collecting a point in time at one point in the quarter, at the end of a quarterly time period. But the client is being asked, for example, about how they were feeling, how they're feeling today at this moment in time, or how they were feeling over the course of this 1 week period. So it's really important to use the tools in accordance with, and again, it sounds you know, sort of self-evident, but in accordance with the specific directions of the tool itself. So the standardized tools are really great because, as David highlighted earlier, they've been normed, they've been developed and researched to measure what they say they measure. And they provide great information as to change of symptoms over time, how clients are doing. And again, they can be used clinically to prioritize specific areas of symptomatology, goals, and there are just lots of ways they can be used. And I really do want to emphasize that it's important to really think about the tool within the context of all of the information we collect. So if the client is not meeting treatment goals, but is reporting low symptomatology, or vice versa, as Julie highlighted earlier, that's a really good jumping off point for discussion, and to be able to talk with the client directly to use the information. In the same vein, both clinicians and supervisors really need to be you know, using the tools and understanding the tools so that the supervisor can, you know, in an ongoing way support the clinician in using it. And Julie's going to take us through the development of an outcomes measure plan for the clinic.
Thank you. Basically, you'd want to start with a plan, do, study, and act. And what that means is, first you need to make a commitment that you want to make a change. And so you need to be planful about how the change is going to occur. So if you're not using any kind of an outcome measure, and you want to start using them in your clinic, or if you're a clinician and you have the approval of your supervisor, I had to put that in there, a little legal disclaimer. How are you going to implement the tool? What tool are you going to use? What are you looking to measure? So when you figure out what you're looking to measure, whether that's for a full clinic or just a specific clinician, whether that's symptomatology or the outcome measures that I was speaking to before, really looks at engagement and the therapeutic relationship. So as part of the planning process, what do you want to measure? What's an appropriate tool that will allow you to measure what you're hoping to capture? And as part of that, what I would also suggest is figuring out a plan and a protocol as to how are you going to use the tool, how often, with what clients, in what capacity, and then how are you going to use the information that the tool gives you. For me, that's all part of the plan process, and I always do the plan process in pencil because you're going to think you've answered all the questions, you have it set up, and then, as anybody who knows who's ever done any kind of a pilot program or pilot project, all sorts of things happen that you didn't expect, and you think you're going to end up at B and you end up at Z. Then you're going to implement the tool and you're going to follow the process that you put into place under the plan, and you're just going to gather data at that point. So again, at the due point, you're just implementing the plan. The next step really is to study, and again, you're going to assess how long do you want the pilot project to go for. And during the study, you're going to consider the information that the data has given you in the plan and the due. So if I was going to use the session rating scale, and as a clinician, I'm really interested in my engagement and the therapeutic relationship because it's my belief that that can really help improve treatment outcomes, how often am I going to do that? How often am I going to use the tool, with what clients, and as I'm getting information back, let's say I'm going to use the tool for 2 months, then I'm going to gather all the data, and I'll make an opinion or a decision at that point whether I feel the process and the protocol that I set up is working. Is my no-show rate decreasing? Is that one of the things I'm looking at with the session rating scale? Is the outcome measure that I've decided to use, is it giving me the information that I need to make my decisions, okay? And then lastly is the ACT. I'm going to use the data to facilitate either the process to other people, recycle the process. Sometimes, believe it or not, when we come up with a pilot project or we have an idea about how things are going to work in real life, when we actually implement it in clinic, again, we think we're going to end up at D and we end up at Z. And so a lot of times it's really a recycling of the plan, do, study, check, and act. So basically, I selected my SRS tool, session rating scale. I think that if after each session I send out a little thank you card on agency cardstock that says, hey David, thanks for coming in today. Remember your homework that you were going to think about 3 things that make you happy. And if I send that out, and I'm going to do that for a period of 2 months, does it give me the outcome that I expected? Sometimes the answer will be yes, great, what I did, this outcome measure that I've chosen is giving me all the information that I need, and I can use that information in my clinical practice. Sometimes what will happen is, well, you know what, it seems that with people who have this specific diagnosis, it doesn't really seem to be working, so maybe I need to do something different, and then go back and look at the plan.
Great. Thank you so much, Julie and Elizabeth and David. I really appreciate your presentation today and how thoughtful you've been about talking us through outcome measures and thinking of them as clinical support tools and the what, why, and how. I'm going to ask anyone who has questions to please type them to me in the chat box. And I also just want to remind you that this is our first webinar on this new system with Seatac. If you can please stay just for a minute to fill out the feedback, we'd really appreciate that, and so you can help us figure out any glitches or anything we could do differently next time. Okay, I have one question from Mary Lee Burns, and she wants to know, have you used the DLA-20? Who would like to answer this one?
I actually have used that tool. We did have a pilot project with the DLA-20, and what we did is we asked, I believe, a few volunteers from each clinic to use the form. We did it at intake, and then we were also doing it at each IAP or treatment plan review 90 days out to measure progress. Basically, for those of you guys who don't know what the DLA-20 is, it is maybe it has 20 questions in different domains, and it is reported to give you a more accurate GAF score that is reliable and consistent regardless of the rater. Like for me, I know that I typically give a low GAF score. Obviously, I think my score is correct, that's why I give it. And when I review other people's GAFs, I find they have a tendency to give high ones. And so the DLA-20 is reported to bring the scores into alignment regardless of the rater.
Okay. Thank you so much, Julie. We have a question from Susan Binsky. Where can we find the resources and tools to use to measure? So I think a lot of people are wondering where they can find the session rating scale and other measures that were mentioned today. That's why I put up the resource page, but if Julie or Elizabeth have anything to add to that, please do.
What I would add to that, this is Julie. What I would add to that is, as an agency, we do use the ORS and the SRS session rating scales at Spectrum, which is great, and there's a lot of administrative support for the use of both of those tools. However, before I came to Spectrum, I worked at a different agency, and I had a colleague who was working at Spectrum and told me Scott Miller was coming to Spectrum and about these tools, and I had heard about them as well. And so even though the agency that I was working for wasn't utilizing the tools, I was able to go online, get the tools. There was enough information that I would be able to use them in my own clinical practice. And so what I chose to do, even though it wasn't an agency tool we were using, I really wanted to become the best therapist that I could be, and so I used those tools in that manner, which is really how they were intended.
Great. And I would just add, thinking about what this, I think, has a lot of resources to get folks started. All of these, you'll be able to even delve into these different sites and get additional information. And the only thing that I would say is to think about both before and while you're looking for the different through the different resources. Again, what it is you're looking to measure. Is it an overarching symptom tool? Is it to better understand engagement? You know, that will really help you define where you want to start in terms of identifying the tool and then selecting the tool. And again, I can't emphasize enough that Plan, Do, Study, Act process. It's essentially, as one of my colleagues puts it, it's thinking about what you're doing with the client is you're assessing and reassessing over time. The Plan, Do, Study, Act process is essentially that same thing, but thinking about it for the work that you're doing. You're constantly assessing and reassessing over time. Is it having the impact that you want it to have? And if not, you know, what do we do next? And if so, how do we keep doing it and do more of it?
Thank you, Elizabeth. Thank you. I also have a lot of questions about any recommendations for specific populations. People are wondering, I think you answered this a little bit, Elizabeth, but for example, high-risk clients. Any recommendations about specific outcome measures pertaining to the assessment of engagement with high-risk clients? Kay Jackson was wondering.
The session rating scale for engagement works independent of any diagnosing. diagnoses. So it's really applicable for most clients who will be coming into clinic. Obviously, I would think if somebody were in a crisis situation, then the outcome measure for that session isn't administered. Or if somebody is having a lot of psychotic symptoms that may not be able to answer or understand the questionnaire, but the SRS and the ORS is appropriate for every diagnosis, whether that is mental health and or substance use disorders.
And I would just add that, and I don't see it on our resource list, so I can definitely get that to Kara to send out there. But there is a tool that recently, or that's out from Columbia on specifically around suicidality, and I can get information on that to Kara to send out. That'll to help assess for suicidality.
Thank you, Elizabeth. I think some more questions are pertaining to specifically with kids or with adults. Anything in particular? Does the session rating scale, is it used with children as well as adults, as well as the outcome rating scale?
Sure. The SRS and the ORS do have versions for use with children, and they have adult versions, and it also comes in many different languages. And the children's SRS and ORS, depending on the age, I would think could go as low as probably 4. Now, instead of the Likert scale, they're really asking somebody to complete basically a blank face, which would either be a smiley face, a neutral face, or an unhappy face for younger children. But they do have it for different age groups.
Thanks, Julie. Are there any other questions? If so, you can please chat them to us. I just want to thank again our presenters today. And I did go on to the Feedback Informed Treatment website that the presenter submitted to me, and it was really helpful. I got to download all of these scales. They came in Word documents, so I want to encourage you to do that if you're interested. Any other questions? Oh, here's a question about free outcomes. Are they free, or do we have to pay for them?
The SRS and the ORS, they are available for use by clinicians that would not have a cost associated to them, as when I was using them independently at the last clinic I was working at. If you really want to get into, at the administrative and organizational level, use of the tools, there's a lot of support and training that's available to the agency that you do have to pay for, and they do have a program or two that will analyze the data from the ORS and the SRS. But the reality is, if you're on a tight budget, which many of us are, I believe you can use those without cost in a manner. You won't have all the bells and whistles.
And just looking at the resources listed, so like the SDQ, I believe is available at no cost. I think I also mentioned the CESD, and that's up there. That is available at no cost. Other tools that I had mentioned, including the OQ and the Basis 24, those both do have costs. But as Julie mentioned, there are different levels that the publishers have. So you can purchase the electronic system, you can purchase the paper system, and so there are usually different costs that you can that are available to access the different tools that are out there. But there are a lot of tools that are in the public domain that are available.
Thanks, Elizabeth. We have one more question from Steve Valley. Please describe how you have collected aggregate data so that we can identify trends across our clinics. Very good question.
Okay, so what we've done is that we have collected, we've had the outcomes questionnaires and the different tools that are used, and we collect them centrally and do enter them into a single database. so that helps us to both analyze the data and provide feedback to the individual clinics. We can look at the data across diagnoses, and then we can look at the data across all the different sites that we have. So what we do is they are administered by clinicians and used clinically, and then we collect that data and enter it into a centralized database so that we can look at it at an aggregate level.
We have an opportunity with the measures that we're using. We enter the measures. We utilize the software support, and then we're able to download that information at a number of different aggregate levels. You can take a look at it at a granular level. You can aggregate it up to a clinic level by location and aggregate it up to a clinic location, a total clinic. And then we're able to then take that information and utilize it over time. So I think that the point that Elizabeth's making and that we're making is that as you use these tools, if your intention is to move beyond the informing the individual clinical intervention, and you want to aggregate and look at it objectively, you are going to have to build a infrastructure that will allow you to gather that information in a structured format that you can do your analytics and metrics against. There's certainly with some of the measures a process that can be done in-house, and as we've talked about, there are also certainly services attached to some of these measures that will streamline that process. And part of the comments that I made before is that I think as you plan this and put it into place, I think for many clinics you'll find the value returned to the clinic, to the clients, and to your clinicians will exceed the cost. And we should be thinking about this as another tool that is necessary that leads to better outcomes, better services, and more efficiently run clinical operation.
And
Thank you, David.
What I would add to that is going back to David's example of a car. So he wants to buy a car, and I'm sure he'd really like a Mercedes or something, a Bentley, right, that has everything that he wants the car to do and more. But it then goes back to what do I need and what can I afford, and working up to the Bentley.
Great. Thanks, Julie. One last question along those lines is, are there any tools that readily integrate into the electronic health records, or is data aggregated outside of the electronic health record?
It would really depend on which electronic health record that you utilize.
Okay.
Yeah, I think that different records have different abilities, and so the platform that we're on, we are able to develop within the EMR tools, assessments, those kinds of things. And there might be opportunity either with the vendor or even with some of our own work to be able to take a tool and integrate it into the EMR. I am not familiar with enough of the EMRs to speak to whether there are any of these outcome tools that get embedded out of the box. My guess would be that there's not much that's currently in place. Elizabeth, do you have a different take on that?
No, I agree. I think it depends on the system, and it depends on the tool and the permissions associated with the tool. And the systems, again, as you mentioned, the systems that each tool has in place. So it depends on a lot of different factors. And, yeah, no, I don't have anything further, unfortunately, to add on that.
Also, somebody had asked a question related to the Columbia suicide. I have the name of that form for you now. It's the Columbia Suicide Severity Rating Scale. That's the Columbia Suicide Severity Rating Scale, and it really seems like OMH is very invested in that tool.
Okay, thank you, Julie. And I just want to thank all three of our presenters again, David, Julie, and Elizabeth. And I wanted to remind our audience that all three of our presenters are part of our business team here at Seatac. And I want you to be on the lookout for some exciting emails from our business team, and it will encourage you to go to our website. And on that note, our website is under construction as we're revamping. As you all know now, we are looking at serving adult clinics as well as children clinics. So here are some upcoming Seatac events. We're very excited to have the National Council Community Behavioral Healthcare Specialists Linda Laginza and Cheryl Sharp, who will be presenting two webinars, one on mitigating disaster trauma, the role of the outpatient mental health clinic, on December 18th from 12 to 1, and then one on January 7th, compassion fatigue, on January 7th from 12 to 1. That's a Monday. Normally our webinars are on Wednesdays, but we have so much interest on various topics that they'll be through different days from now on, just to let you know. Thank you again for everyone for participating in our webinar today, and thanks again to our amazing presenters. I hope you have a wonderful day and a wonderful holiday, and we look forward to seeing you soon. Please contact us if you have any questions or concerns. Here's my email, karadean@mssm.edu, and you can always go on our website to get more information. You can contact Justine Lai if you have any questions about business practices. Take good care and have a wonderful day. Bye-bye.